Good afternoon. I'm Bob Blum, and the head of the Johns Hopkins Urban Health Institute. And it's a pleasure for me to welcome you today to this presentation and conversation. Let me tell you about the series that we are hosting and have for the last 2.5 years. It's a series on race, racism, and research. It is a series that is not intended to be a lecture where people listen, go home, have dinner, and keep on going. It is intended to be a series where people listen, talk, think, and engage in conversation with neighbors, both within the university and between the university and our neighbors who live around us here in East Baltimore and Baltimore. It is a series that has as its intent for us to look at ourselves, our work, and how we do our work and could do our work differently. So this is a conversation. Camara Jones, welcome back. It is a pleasure to have one of our own graduates of the Bloomberg School of Public Health return as part of this lecture series. Dr. Jones graduated from undergraduate work at Wellesley College, went on to Stanford University, to medical school, came here to Hopkins in the School of Public Health, where she did her doctoral work in epidemiology. She taught at the Harvard School of Public Health. For those who don't know, that's up in Boston. And then in 2000, went to the Centers for Disease Control. She's research director of the Social Determinants of Health and Equality at the CDC, Epidemiology and Analysis Program Office. She is one of the country's most insightful researchers on issues of race and specifically racism and the consequences of racism. And she is an extraordinary speaker. For those who have heard her here before, they implored us to invite her back. And so we're so pleased that it worked for you to return. I'll turn the podium over to you. The way this symposium is structured is that when Dr. Jones finishes, I will introduce the three equally extraordinary panelists who will respond and reflect on what they have heard, and then we will open it for a conversation with everyone here. So thank you for coming, and Dr. Jones, welcome.
Wow, it's great to be back here, and thank you, Dr. Blum, for inviting me to do this. And I'm really heartened that the Urban Health Institute is doing its work. It's been in existence now for 10 years, and I'm heartened that this work is ongoing and that there's an effort for the Johns Hopkins institutions to really engage with the East Baltimore community and the Baltimore City and urban health. I usually like to have the conversation going along, but being respectful of the time and the insight that my panelists are going to bring, I'm going to just share a lot of different thoughts with you. Some of these are going to be frameworks for understanding the impacts of racism on health. I'm going to share data with you, a cartoon framework for understanding levels of health intervention. And if you have questions or challenges or insights, just write them down for right now, because I want to just share everything, put everything on the table, and then we're going to have a great big old conversation. I have to say, since I'm at CDC, that the findings and conclusions in this presentation are my own and don't necessarily represent the official position of the U.S. government. So I'm going to start out with a cartoon that's going to talk about different levels of health intervention. So here we are, whoops, boom. Somebody has just fallen off of the cliff of good health. And if that's you, or if it's somebody in your family, you would be delighted to find an ambulance there at the bottom of the cliff to speed you on to care. But if we're concerned about others who may come along that cliff, if we're concerned about public health or population health, we might ask ourselves, what else can we put in place as a health intervention besides just stationing lots of ambulances there at the bottom of the cliff? So somebody in this room is going to say, I know, let's put a net halfway down. So even if people fall, we can catch them before they get crunched up at the bottom. But we all recognize that nets have holes in them, so some people will fall through the cracks. So we might even make that a trampoline halfway down. But even if we had a trampoline halfway down, no holes, we still might find people bouncing up and down at half functionality, not really able to get back to the top of the cliff. So what else can we put in place as a health intervention? Well, certainly we should put a fence at the edge of the cliff to keep people from falling in the first place. But, okay, the sound is echoing now. And it was fine before. You guys could hear me before, right? So just turn it down a little. Okay, now we're good. So we're going to put a fence at the edge of the cliff. But that's got to be a very, very strong fence if there's a lot of population pressure against it, right? So what else can we put in place, or what else can we do as a health intervention? We can move the population away from the edge of the cliff. So I'm going to label these health interventions that I've shown so far, where the ambulance at the bottom of the cliff is clearly about medical care and tertiary prevention. For those of you who are not public health people, tertiary prevention is stopping the complications for disease from disease that's already there. So preventing amputations from diabetes, that type of thing. The net or trampoline, these are our safety net programs and secondary prevention, screening programs, early detection. The fence at the edge of the cliff are our primary prevention efforts, including things like immunization that prevent disease from occurring in the first place. And moving the population away from the edge of the cliff is about addressing the social determinants of health. So this means addressing issues like poverty and adverse neighborhood conditions, educational opportunities, housing, and the like. So this little diagram actually could be quite useful for engaging a community and discussing how should we be allocating our health resources. Where should our efforts be focused? And people will say, well, we need some of all of it, but a lot of people will probably vote for moving the population away from the edge of the cliff. But as useful as this diagram might be, so far it's lacking because it does not yet address how health disparities arise. So I want you to keep the cliff in the back of your mind. We're going to shift gears for just a second to talk about how health disparities arise on 3 levels, and then we'll come back to the cliff. How do health disparities arise? Well, especially when we're talking about racial ethnic health disparities, we have lots of evidence, unfortunately, about differences in the quality of care received within the healthcare system. So in 2002, the Institute of Medicine released its Unequal Treatment Report, which pulled together evidence from hundreds of studies at the time about differential treatment in terms of heart disease, even in terms of if you broke a long bone and ended up in an emergency room, depending on your race, that would affect how much pain medication you got. I know. Well, I appreciate amens and questions and challenges along the way. We won't have a long conversation, but if you have any little things like that out of the audience, yes. But even that panel that wrote that Institute of Medicine report knew that, of course, there are also differences in access to health care. That's a second level at which health disparities arise. But even before people are seeking health care, there are differences in our life opportunities, exposures, and stresses that are making some individuals and communities sicker than others in the first place. And actually, when you think about these three levels at which health disparities arise, it's like a huge iceberg or a pyramid, and the base of it are the differences in the exposures and opportunities in our lives. And then you have some individuals and communities sicker than others, and then they are frustrated often by differences in access to care. And then even the lucky ones who get into the healthcare system are sometimes further injured because of differences in the quality of care. So now, remembering these three levels at which health disparities arise, differences in quality of care, access to care, and underlying exposures and opportunities, we're going to go back to our cliff. But now we're going to recognize that really we're not dealing with a flat two-dimensional cliff, but actually we're dealing with a three-dimensional cliff. And there may be an ambulance there over here, but maybe that ambulance has a flat tire, so it's slow or goes off in the wrong direction. Or maybe there's no ambulance there at all, and maybe there's no net nor fence. And usually at those parts of the cliff, the population is being pushed closer to the edge. So now I'm going to label these observations about our three-dimensional cliff with how health disparities arise. Where the differences in quality of care that we talked about, that's when the ambulance is there, but it's slow or goes off in the wrong direction. Differences in access to care are no ambulance, no net, no fence. And the differences in underlying exposures and opportunities are the closer proximity of that population to the edge. Now, you'll remember that I described addressing the social determinants of health as moving the population away from the edge of the cliff. But now, recognizing that we have a three-dimensional cliff, we have new questions to answer and new things to do. That is, the first question is, how did the cliff become three-dimensional, right, in the first place? And that often is because of historical injustices, which are perpetuated by contemporary present-day structural factors. But given that we have a three-dimensional cliff, we need to also know, why are there differences in how resources are distributed along the cliff face? And why are there differences in who's found at different parts of the cliff? And when you start addressing these kinds of questions, you are now addressing the social determinants of equity. And these social determinants of equity are decision-making processes and systems of power, like economic systems and racism and sexism and the like. So in this cliff, where I've been talking about three levels of health intervention, I've actually distilled three dimensions of health intervention, where health services can be represented in a single line along the cliff face, ambulance, net, fence. And this is where, in our nation, if you say something about health, this is where people are in health services. In fact, our whole conversation over the past several years about health reform has really been about trying to get universal access to high-quality health care, but that's all in the health services realm. Now, that's important because that's the prerequisite, I think, for living in a civilized society, to value all of our population equally and have universal access to high-quality health care. But that in and of itself is not going to provide us with large or sustained improvements in health outcome. In order to do that, we need to move the population away from the edge of the cliff. That's the second dimension. In fact, you can display this in a flat plane in 2 dimensions. And we need to address the social determinants of health, like poverty and housing conditions and education. But you know, we can be focused on addressing the social determinants of health and moving the population away from the edge of the cliff, but if we don't understand that we're dealing with a three-dimensional cliff, we can actually make health disparities worse, because we could move some of the population but not all of the population. So in order to fully address health, we need to also understand and move into three-dimensional space and address the social determinants of equity, which include racism and other systems of power. I'm going to shift gears for just a minute, so I'm going to invite all of these people who are standing here to come in the front. Just come on right now. This is your time. Come quickly, though. And people who are sitting on the edges, if you can sort of fill in, you know, if you can just move a few seats toward the middle, everybody, so that as more people come in, there'll be easy places for them to sit. So this little cliff analogy that I've shared with you has been about levels of health intervention. But now I'm going to say some of the same things, but from a slightly different perspective. And that perspective is going to be to try to answer what is pushing people closer to the edge. That is, what are the determinants of health? And if I were to do a poll here in Baltimore about the determinants of health, you know, a lot of people would tell me about individual behaviors, right? In fact, even at the CDC, we have a heavy investment in trying to get people to eat 5 to 9 servings of fruits and vegetables a day, or decrease their salt intake, or decrease their fat intake, or exercise 30 minutes a day at least 5 days a week, or to stop smoking or never start, or to decrease your alcohol intake, or never start, or safe sex, and on about individual behaviors. And why is that? Well, it's because individual behaviors do matter, right? It does matter what you put in your mouth. But when you take a step back and ask a why question, why do some people put certain things in their mouths and other people put other things in your mouths, then you realize that we have to expand our gaze beyond the narrow focus on individual behaviors to address the social determinants of health, which I define as the determinants of health and illness that are outside of the individual. That is, these are the things beyond our genes, beyond our individual behaviors, and they actually are the context in which individual behaviors arise and convey risk. So these social determinants of health include our individual resources like education, occupation, income, wealth. These are the things we call social class, as well as place-based or neighborhood resources like the quality of housing stock in our neighborhood, or the availability of fresh fruits and vegetables. Is there even a grocery store in your neighborhood? Public safety issues. Is it safe to go walking? Transportation, can you get to a job? Parks and recreation, can your kids go out and play and commune in nature, or are the parks where the drugs are being sold? Political clout of different neighborhoods. And these social determinants of health, these contexts also include concentrations of hazards and toxic exposures that could be either place-based or occupationally group-based. For example, concentrations of exposures to less pesticides or lead or reservoirs of infection. And they can also include concentrations of the good things, like opportunity structures, concentrations of quality schools or available jobs, or even having the justice system work on your behalf. So now you see, if we want to do something about health, yes, we have to focus on individual behaviors to some extent. It does matter what you put in your mouth, but what you put in your mouth is either made easier, facilitated, or harder, constrained, by whether or not there's a grocery store in your neighborhood. And so if we really want to do something about health, we have to pay attention not just to the individual behaviors, but to the context. But then, remembering the three-dimensional cliff, we might need to ask another why question. Because you see, it doesn't just so happen that some neighborhoods have grocery stores in them and others don't, and that some people are concentrated in certain types of neighborhoods and other people are concentrated in other types of neighborhoods. And if the social determinants of health are the context, we need to ask a further question to enlarge our gaze to talk about the societal determinants of context, and to ask what determines the range of neighborhoods here in Baltimore, and what determines who lives in which neighborhood. And when you start engaging in these questions, you're now talking about systems of power that include economic systems, including our own economic system, capitalism, which, as much as we celebrate it in this country, or at least have until about 2 years ago, as much as you might want to love capitalism, we have to recognize that capitalism creates class structure because some people own the factories and other people work there, right? And systems of power like racism, which are I'm going to talk a lot more about racism in a minute, but this is a system that differentially shuts people into different life opportunities in different classes, and other systems of power, including sexism and heterosexism and the like. And these are what I was describing earlier as the social determinants of equity. So if we're going to do something about health, yes, we need to talk to people about what they're putting in their mouths, but we have to also address the social determinants of health, the context, the neighborhoods. And we have to also address the decision-making processes that result in the range of neighborhoods that we see and determines who lives where. So beyond individual behaviors, we need to address the social determinants of health, including poverty, if we're going to achieve large and sustained improvements in health outcomes. We have to move the population away from the edge of the cliff. But we also have to address the social determinants of equity, including racism, if we're going to achieve social justice and eliminate health disparities. In other words, we have to be sure that we move all of the population away from the edge of the cliff. So now I'm going to define racism for you. When I talk about racism, I'm very clear that I'm talking about a system. In other words, racism is not an individual character flaw or a personal moral failing or even a psychiatric illness, as some people have suggested. But it's a system of power. And a system of doing what? It's a system of structuring opportunity and of assigning value. And on what basis is the opportunity structured and on what basis is the value assigned? It's based on the social interpretation of how we look, which is what we call race. So here I am in Baltimore. You look at me, and I am clearly black. But in Brazil, in some parts of Brazil, you would look at me, and I would be just as clearly white, believe it or not. In South Africa, you'd look at me, and I would be clearly colored. So in 3 different settings, I'd have the same physical appearance, but the social interpretation of my appearance would assign me to 3 different racial groups. And if I were to stay in any of those settings long enough, then my health outcome would even take on that of the group to which I've been assigned, even though I'd have the same genes in all 3 places. So if racism is a system of structuring opportunity and assigning value based on the social interpretation of how we look, what are the impacts of this system? Well, racism certainly unfairly disadvantages some individuals and communities. And when we think about or talk about racism at all in this country, this is how we think about it. But it doesn't take long to understand that every unfair disadvantage has its reciprocal unfair advantage. So this system is also unfairly advantaging other individuals and communities. And this is the whole issue of unearned white privilege that we hardly ever talk about in this nation. But then even as we acknowledge that some individuals and communities are either unfairly disadvantaged or unfairly advantaged, racism is sapping the strength of the whole society through the waste of human resources. And we can see that very clearly in how we as a nation don't invest in the full, excellent public education of all of our children. It's almost as if the blinders of racism have made us think it's impossible that there's genius in the barrios or in the ghettos or in the reservations. The blinders of racism have made us so differentially value our children that we think we could get along very well, thank you, without those kids. Right? But if we were to invest in all the genius that is in the barrios and in the ghettos and in the reservations, we could be doing so much better as a country or even as a world. I think that we would be farming on Mars already if that were a good idea to do, if we were to invest in all of that genius. Another example of how racism saps the strength of all of us is how it has made us complacent to the wholesale warehousing disproportionately of so many of our black and brown men in the prison system. As if that did not represent a loss of human potential. I don't know if you have known people in the prisons or gone to work in the prisons, but if you do, there are many geniuses up there in the prisons that if they only had some other way, they would be able to contribute vastly to our society. Even the way that we as a nation are unaware of, many of us, unaware of or unconcerned about or not passionate about the health disparity statistics. It's almost as if, well, if my aunt dies 8 years before her time, that might be a problem for our family or maybe her church. But we're not understanding it as a problem for the nation because we have lost everything that she has to offer. And so I actually think that we need to name racism, first of all, and understand it as a system of structuring opportunity and assigning value based on so-called race. But of all of these things, our focus, I think, really should be in our data collection, in our media stories, in our storytelling, in our sharing with one another about how racism saps the strength of the whole society, because that is how we will motivate all of us to dismantle the system. So now I'm going to share with you some data from the CDC that are trying to elucidate some aspect of racism and health. And you'll see that we use that definition that I have as the basis of some of this analysis. So there is a reactions to race module, which was developed by the Measures of Racism Working Group at CDC and first introduced as an optional pilot module in 2002 on the BRFSS, Behavioral Risk Factor Surveillance System. That is a telephone survey that's done by each of the states in cooperative agreement with CDC. You know, every month they call some population-based number of people and they ask them questions, right? And this is how we know about the obesity epidemic and smoking rates and all like that. And so there's a core set of questions that every state asks, and then there are optional modules that states can opt into or out of. Our 6-question reactions to race module starts with the question, how do other people usually classify you in this country? So that's getting at that notion of race as the social, interpretation of how we look. And I'm going to talk a lot about this question in a minute because that's the analysis I'm going to show you. The second question on the module is, how often do you think about your race? Would you say never, once a year, once a month, once a week, once a day, once an hour, or constantly? And we're using that question not only at the individual level to look at how that race consciousness correlates with health outcomes, but also as the basis on an aggregate model for developing a measure of racial climate. We can talk about that more in the question and answer section. The next two questions are about perceptions of differential treatment, either at work or when seeking health care, and we allow respondents to say that they were treated either worse than, the same as, or better than. So it allows people to acknowledge if they recognize it, better than treatment. And the final two questions are about reports of either physical symptoms or emotional upset as a result of how they were treated based on their race. There, between 2002 and 2009, I haven't updated this slide yet, but there are 22 states that use the module at least 1 year. 6 states have used it 2 or 3 years. The states in blue use the module, but not as the official optional module. So they either put it somewhere else or they use some of the questions. I'm going to show you analyses from 2004 where 8 states use it as an official module. This was the first time when the module was available to everybody. You'll see that Maryland hasn't yet used it. We haven't really marketed it yet. I'm going to go in 2 weeks, and I'm going to go to the BRFSS meeting, and I'm going to really market it now. But anyway, you all who are here in Maryland can just contact your state health department, talk to the BRFSS coordinator, and say you'd like them to use this so that you can have the data to analyze. But anyway, I'm going to aggregate the data from those 8 states, and we're going to try to learn something about racism by looking at this question: how do other people usually classify you in this country? Would you say white, black, Hispanic or Latino, Asian, Native Hawaiian or other Pacific Islander, American Indian or Alaska Native, or some other group? And the first thing you notice about this question is that it's not asking about your race or ethnicity. It's asking how do other people usually classify you, and also that the response categories combine the federal racial categories with the federal ethnicity category. We don't make any artificial distinction between so-called race and so-called ethnicity. And this question is really trying to get at the on-the-street classification of people in our race-conscious society that does not have the benefit of asking how do you self-identify, or the benefit of who were your parents, or where were you born and where were they born, or even may I see your genotype. This is the on-the-street racial classification of people that is the substrate on which racism operates day to day. And we call this variable socially assigned race. Because this is a telephone survey, the BRFSS, we don't have measured health stuff, but we do have this question: would you say that in general your health is excellent, very good, good, fair, or poor? And this question has been shown to be, if you only had one question to take with you to a desert island, this would be it. This is a gold standard type of question because, especially when you're looking at the fair or poor health, it's been found to be highly predictive of future morbidity and mortality. We are interested in looking at the positive sides of things. So we're going to look at excellent or very good, the number of respondents who report their health to be excellent or very good. And I'm going to roll out a series of analyses. So the first analysis is very basic. What proportion of people who are usually classified by others as either white or black or Hispanic or American Indian, Alaska Native report their health to be either excellent or very good? I'm going to put some 95% confidence intervals on those bars, and you see that people who are usually classified by others as white report significantly more excellent or very good health compared to the other groups. And if you prefer to look at fair or poor health, where green is excellent or very good, the white space in the middle is good, and the red at the top is fair or poor, then people who are usually classified by others as white report significantly less fair or poor health than members of the other groups. So this is going to be the first part of an evolving story, which is that being perceived as white appears to be associated with better health. But now you're wondering, what is this socially assigned race anyway, and how does it relate to self-identified race ethnicity, which of course we also have on the BRFSS. We have the question, are you Hispanic or Latino? Yes, no. We have the questions, which one or more of the following would you say is your race? And then if you pick more than one, which best represents your race? And we use the combined race ethnicity variable that most people use in research these days, Hispanic, non-Hispanic white, non-Hispanic black, and the like. And this is how it's constructed. If you say yes to Hispanic or Latino, you get Hispanic or Latino. It doesn't matter what you say for race. If you say no to Hispanic or Latino and you pick one race, you get that race. If you say no to Hispanic or Latino and you pick more than one race, you get more than one race as your racial classification. So here's how these two measures of race compare. For the 26,000 plus respondents who self-identified as white, 98% were usually classified by others as white. For the 5,000 plus respondents who self-identified as black. 96% were usually classified by others as black. And so even though it's not 100%, you might be surprised at that, but it's pretty high concordance. But when you get to those who self-identified as Hispanic or Latino, are you Hispanic or Latino? Yes. 63% were classified by others as Hispanic or Latino, but fully 27% were classified by others as white. So this gave us a very interesting analytic idea, which is to look at the self-identified Hispanics, who are usually classified by others as Hispanic, and compare their self-rated health with self-identified Hispanics, usually classified by others as white, and compare them also with self-identified whites, usually classified by others as white. So the next slide is going to have these three groups: Hispanic Hispanic, Hispanic white, and white white, in terms of yeah, you know what I'm talking about, right? Okay, right. And here are the proportions reporting excellent or very good health. So you say, well, I don't know, look at that middle bar, that's pretty interesting. It's kind of in the middle there. Are any of these differences statistically significant? So let's look at pairwise comparisons. If you compare self-identified Hispanics, usually classified by others as Hispanic, with self-identified whites, usually classified by others as white, that large difference is also statistically significantly different. That p-value less than 0.0001 means that a difference that large or larger you would see by chance just less than 10,000. What about within people who self-identify as Hispanic? There's also a large and statistically significant difference there, depending on whether other people usually classify you as Hispanic or as white. Or what about comparing people who are usually classified by others as white? It doesn't matter if you say I'm Hispanic or if you say I'm white, there's no evidence of difference in the proportion reporting excellent or very good health. So you go, Did anybody go, Can I hear it? Okay, so are there any other groups where we could look at this? Well, yes, American Indians or Alaska Natives. These are people who said, are you Hispanic or Latino? No. Which one or more race? They picked one race, American Indian. So that's not me with my Cherokee great-grandmother. And of these people, 36% usually classified by others as Indian, but fully 48% usually classified by others as white. So we're going to look at Indian, 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 white, 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 okay? This is what we see. Indian, Indian, white, white, significant difference. Among people who say, I am American Indian, depending on whether other people usually classify you as Indian or white, a large and statistically significant difference in reporting excellent or very good health. Doesn't matter if you say, I am Indian or I am white. There's no evidence of difference there. There was another group, and we actually published this paper in 2008, so you can get the reference. But there's another group also, which were the more than one race people. And the groups we compared, there were more than one race black, more than one race white, white. It was the same, even more extreme difference. I don't have these here. But this adds to our story. Not only is being perceived as white associated with better health, that's true even if you say, I am some non-white group. Now, I don't have time to show you the differences within educational level, but even within the education, if you want to look at socioeconomic stats, if you're socially identified or socially assigned white, you have better health, even at the lowest educational levels. And it's even true that being perceived as white is associated with better education in the first place, and better housing and better income. I mean, we know these things. And so the question is, why? Why do we see an association between socially assigned race, especially socially assigned whiteness, and better health, better education and the like? Because there's no a priori reason that looking a certain way should make you healthier or have better anything, except that we live in a society that structures opportunity and assigns value based on socially assigned race. And so we take these data as preliminary but very compelling evidence of the impacts of racism on health. This is not just some little spurious thing that I'm making up. This paper was actually nominated for CDC's highest science prize. We didn't make it, but we were in the running. And it's in Ethnicity and Disease in 2008. And if you can't find it, then I can send it to you. I'll have my email at the end. So now, how could racism do something like this, right? To answer that question, to answer the question, how could racism be causing diabetes excess diabetes in Baltimore, I find it useful to look at three levels of racism: institutionalized, personally mediated, and internalized. It's also useful to look at these levels to figure out how to intervene. You know what? before I do that, there are people way backed up. So there are some seats in the front. And again, if you're sitting on the edge, if you can move toward the center, everybody who's sitting back there, come on and sit down because I'm about to shift gears. And I want you guys to be here. Okay? So now I'm going to shift gears and talk about racism on 3 levels so that we can understand how could it be impacting health. So I'm going to define each of these levels of racism, give you some examples of how it could affect health, and then illustrate these levels with a teaching story, one of my allegories. Institutionalized racism is that system that results in differential access to the goods, services, and opportunities of society by race. This is the kind of racism that has been institutionalized in our laws and in our policies and in our practices and norms. This is the kind of racism that doesn't require an identifiable perpetrator and often shows up as inherited disadvantage. And we see it both in terms of material conditions and in terms of access to power. So examples include differential access to quality housing, or equal educational opportunities, or equal employment opportunities, or even the same level of income at the same level of employment. And we know that all of these are related to health. Differential access to medical facilities, not just physical access, but linguistic access. Differential access to a clean environment, and the whole differential placement of toxic dump sites in communities of color in poor neighborhoods, and the differential placement of bus depots and the like. And in terms of power, differential access to information. That information could be health information, or it could even be information about our own histories. Differential access to power as resources, not just capital resources, but social networking resources and knowing somebody on the board, knowing somebody who can make something happen for you. And differential access to voice, voice in government, voice in the media. Now, when I show this slide, I have sometimes been asked, Dr. Jones, are you talking about racism or are you talking about social class? Because look at that bullet there, housing, education, employment, income. Didn't you just tell us that that's social class? And that's a very important question, so I'm going to address it. And we start addressing it by acknowledging that it doesn't just so happen that people of color in this country are overrepresented in poverty while white people in this country are overrepresented in wealth. So for each marginalized, stigmatized, oppressed group of color in this country, there's been some initial historical insult. So for American Indians, it was the taking of the land and the genocide, and then the moving of the survivors to reservations. For people who were in Mexico, it was finding themselves in New Mexico, in Arizona, right? It was for Chinese men who were brought to labor on the railroads without their families and being unable to marry, that situation. For people of African descent, it was the kidnapping of West African people, and then our importation across the Atlantic with tremendous loss of life in the Middle Passage. And then the coerced usury of our unpaid labor for centuries to build this country. Oh, well, that's right. She said, don't start it up here. Right, and some people say that. Some people say that, well, Dr. Jones, you're talking about slavery now. And don't you realize that the enslaved people were emancipated in 1865? And that's fully 136 years ago. Dr. Jones, all else being equal, don't you think that the impacts of slavery would have washed out by now? But the key phrase there is all else being equal. And all else has not been equal since 1865, and all else still is not equal today. And there are still today what I describe as contemporary, present-day structural factors that perpetuate that initial historical insult. Thank you, I'll take that. And an example of these contemporary structural factors includes how we fund public schools in most parts of this country based on local property taxes, right? So if you have a poor neighborhood, you're going to have poorly funded schools, which often result in poor educational outcomes and another whole generation lost. Now, that's not a race-based thing, but it's differentially affecting us, and nobody's paying attention to it, right? Nobody's rectifying that. That's one of the contemporary structural factors. So when people ask me, are you talking about racism or are you talking about social class? I say that institutionalized racism explains why we even see an association between social class and race in this country. And that's a very, very important insight, because what it means is that if I had a magic wand to equalize income and housing and education across this country, today, right now, I would do it in a minute. Done. Boom. But if I didn't pay attention to the background structures and policies that are in place, that have been put in place to differentially shunt people into different life opportunities, then in one generation we would start to see a stratification again by race in terms of social class. So we have to do the socioeconomic thing, but we also have to address these mechanisms of institutionalized racism, which, by the way, racism is not some kind of miasma or cloud that we can't get a handle on. It is a system that has identifiable and addressable mechanisms. And that's part of our job, is to figure out what they are. So I'll talk about that in a minute. Before I get off of institutionalized racism, just to say also that institutionalized racism can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. And very often, institutionalized racism shows up as inaction in the face of need. The second level of racism, personally mediated racism, I define as differential assumptions about the abilities, motives, and intents of others by race, and then differential actions based on those assumptions. So this is what most people think of when they hear the word racism. Somebody did something to somebody. It includes the prejudice, the different idea, and the discrimination, the different action. How could that impact your health? Well, police brutality, being pulled over for driving while black or driving while Latino, and then interpreted as resisting arrest and hit upside the head, or worse. Physician disrespect, which can be as subtle as a physician not giving a patient the full range of treatment options because the physician figures that patient wouldn't understand or wouldn't comply or couldn't afford, or whatever the physician assumes. Or it could be quite blatant, like sterilization abuse, which has had many iterations in our nation's history. Shopkeeper vigilance, being followed around in stores, or waiter indifference, not getting quick, respectful treatment. These are parts of the day-to-day racism that just increase our stress levels and maybe our blood pressures. Teacher devaluation. This is a very important manifestation of personally mediated racism. When a teacher looks at a young child and thinks that child can't learn and puts the child over in the ADD track, that child will not even know their full potential, much less be able to develop to their full potential. And so personally mediated racism, like institutionalized racism, can be through acts of doing, acts of commission, as well as acts of not doing, acts of omission. But even more important to realize about this level is that it can be unintentional as well as intentional. That is, you do not have to have intended to be racist to have had a racist impact. The third level of racism, internalized racism, I define as acceptance by members of the stigmatized races of negative messages about our own abilities and intrinsic worth. Here I'm clearly talking from the point of view of the stigmatized races. Other people who do anti-racism work have challenged me and said, well, what about the internalized sense of entitlement that many white people walk around with? Isn't that also internalized racism? And indeed it is. But I put that off in my institutionalized part, so I'm not talking about that right now. But from the point of view of the stigmatized races, how can internalized racism affect your health? Self-devaluation, feeling that maybe you're really not as good as. Maybe you shouldn't try to graduate from high school, or apply to college, or come to the Johns Hopkins, any kind of institution. And I think that this kind of self-devaluation also turns into fratricide, black on black or Latino on Latino crime. Because if you don't value yourself, you're not going to value others who look like you, and you just as soon off them as not. The white man's ice is colder syndrome, that phraseology comes from my parents' generation, and what it meant then and what it still means today for many is that, say that you are black and you need a lawyer, you might go look for a white lawyer over a black lawyer. Or if you need a doctor, you might seek out the white doctor over the black doctor. In fact, if your lemonade was hot, you may go way down the street to get the white man's ice over the black man's ice, deeply believing that the white man's ice was colder, deeply internalizing the myth of white superiority. Resignation, helplessness, hopelessness, I think it turns into a lot of self-destructive health behaviors. I think it turns into not registering to vote or even not voting, even if you are registered. And all of this internalized racism is about accepting the limitations to our own full humanity of the box into which we've been placed. And so when you hear young people of color in the high schools, one of them's trying to be the valedictorian and the others are teasing him and saying, or teasing her and saying, you know, so-and-so is just trying to be white. We need to challenge that, because since when did white people claim exclusive access to excellence? They did not. So I'm going to illustrate these three levels of racism now with an allegory, a teaching story, and I have lots of these stories. I'm still looking for somebody to fund my sabbatical so that I can write my book. But anyway, I keep putting that out there now because one day it's going to hit, right? One day it's going to hit. So all of my stories have been sparked by something I've seen with my own real eyes. So first I'm going to describe what I saw with my own real eyes, and then we'll make it a story about racism. And this story actually has its roots here in Baltimore. And my good friends, some of whom are here in the audience, know about the house that we bought in Baltimore with a beautiful wraparound porch with flower boxes on the porch. So my husband and I, newly married, we're all excited. We buy our house in October. Well, we can't plant flowers in those flower boxes in October, but when spring came, we were all excited. We're going to go plant in our flower boxes. And we looked, and some of the boxes have dirt in them already, but some of the boxes were empty. So my husband goes dutifully to the gardening store and hauls big old bags of potting soil back and fills up the empty boxes. And then we take our marigold seeds and we put equal numbers of seeds in all of the boxes and water them. And I'm not the gardener, so, you know, I just sit back to see what's going to happen. But about 3 weeks later, I'm walking out of my front door, looking at my porch, and it struck me that it looked like we had planted completely different species in some boxes compared to the others. Because some of the boxes were full of plants, and not only were they full of plants, the plants in them were tall and vigorous looking. And some of the boxes just had a few plants in them, and those plants were scrawny and scraggly looking. And then I realized what had happened. You see, that potting soil that my husband had bought, that was rich, fertile soil, so that every single seed planted in the rich, fertile soil had sprouted, with the strong seed growing very tall and vigorous, but even the weak seed in that rich, fertile soil making it to a middling height. But that old dirt that we had found there turned out to be poor, rocky soil, so the weak seed planted in that poor, rocky soil had died, and even the strong seed in the poor, rocky soil had to struggle to make it halfway up. So if you all are gardeners, maybe you've composted half of your garden, maybe you have seen this with your own eyes, and this is clearly an image about the importance of the environment, the importance of the soil. But now I'm going to make it a story about racism by introducing a gardener. So I'm going to have a gardener who has 2 flower boxes, one which she knows to have poor rocky soil, and one which she knows to have rich fertile soil. And she has seed for the same kind of flowers, except some of the seed is going to produce pink blossoms, and some of the seed is going to produce red blossoms. And this gardener prefers red over pink. So what does she do? She puts the red seed in the rich fertile soil and the pink seed in the poor rocky soil. 3 weeks later in her boxes, she sees what I saw in mine. In the rich fertile soil, all of the red seed has sprouted, the strong seed is tall and vigorous, the weak seed at least has survived and made it to a middling height. But in the poor rocky soil, the weak pink seed has died. And here comes the strong pink seed, just trying to make it halfway. And then those flowers go to seed. And the next year, the same thing happens. And those flowers go to seed. And year after year, the same thing happens. Until finally, about 10 years later, the gardener's coming and she's looking at her flower boxes. And she says, you know, I was right to prefer red over pink. We're going to interrupt the story there to say that this first part is how institutionalized racism works, where you had the initial historical insult of the separation of the seed into the 2 types of soil. You had the contemporary structural factors of the flower boxes keeping the soil separate, and then through inaction in the face of need, perpetuation of this inequity. So now we're going to pick the story back up and say, okay, where is personally mediated racism in this garden? Well, the gardener's looking over at red, loving red, but she looks at the pink flowers and she says, oh, those flowers sure are scrawny and scraggly, so she plucks off the pink blossoms before they can even go to seed. Or she might notice that a pink seed has blown into the rich, fertile soil, and she plucks it out before it can establish itself, which is some of the anti-affirmative action stuff that goes on. And where is internalized racism in the garden? Well, the red flowers are just living their lives, probably not understanding that they're benefiting from enriched soil. The pink flowers are looking over at red, thinking that red is beautiful, mighty fine, and wanting with all their hearts to be red. And here come the bees. And the bees are minding their own business, but they're collecting nectar, and so they're pollinating at the same time. So here comes a bee into a pink flower, and then bzzz into another pink flower, and bzzz to this other pink flower, and that flower's like, get away from me, bee. Do not bring me any of that pink pollen. I prefer the red, because the pink flower has internalized that red is better than pink. So now the question is, how do we set things right in this garden? So we could say, okay, well, let's start with the internalized racism. You know, let's go over to the pink flowers and say, you know, pink is beautiful, power to the pink, right? And that's a very important intervention. I'm not minimizing that intervention. That's a very important intervention, but if that's all we do, it's not going to change the situation in which they find themselves. So you say, okay, I can understand that. Well, let's address the personally mediated racism. Let's have a conversation with that gardener. Or better yet, let's have a workplace multicultural workshop for the gardener, which is all good too, right? So we have our workshop, and in the workshop we say, "Dear gardener, would you please stop plucking those pink flowers?" And maybe she will, and maybe she won't. But even if she does, it's still not going to change the situation in which they find themselves. I think that if we really want to set things right in this garden, we have to address the institutionalized racism, which means that we have to either break down the boxes and mix up the soil, or if you want to keep separate boxes too, that's all right, although it makes it easier going forward to continue to segregate resources. But if you keep the boxes separate, it means you have to enrich that poor rocky soil until it's as rich as the rich fertile soil. And when you do that, the pink flowers will flourish. They'll be looking beautiful, grand, and glorious. And you know, sometimes I say this and sometimes I don't. But you know, these pink flowers have been selected over generations for survival and strength. So they might even look a little bit better than the red. You know, I mean, I don't know, just saying. But anyway, that's not germane to the story. So here we have the flowers. We have the flowers equally beautiful now. Well, in that intervention on the institutionalized racism, you will have also addressed the internalized racism, because pink will no longer be looking over at red, thinking that red is better, or wanting to be red. And in that intervention, you may also address the personally mediated racism. Now, that original gardener, she may have to go to her grave preferring red over pink, but her children who grow up and see the flowers equally beautiful would be less likely to have that kind of attitude. So this story has been to illustrate these three levels of racism: institutionalized, personally mediated, and internalized, and to very strongly suggest that if we want to set things right in the garden, we have to at least address the institutionalized racism. Good if we address all the levels at the same time, but we have to at least address the institutionalized racism, and when we do, the other levels may take care of themselves. Now, before I leave the story, there's one more question that I haven't asked yet. That is, who is the gardener? After all, the gardener is the one that I gave the power to decide, the power to act, and control of resources, which in my mind are the elements of self-determination. Now, clearly, government is part of the gardener. In fact, my slide used to say, who is the gardener? Government, power to decide, power to act, control of resources. That was when I was at Harvard. So I'm now at CDC. So and I'm at CDC because CDC is part of the government. I mean, and government is part of the gardener. So, but anyway, so clearly government is part of the gardener, as are the rich people behind government, as are foundations maybe, as are the media, as are communities to the extent that they can claim self-determination. But whoever the gardener is, it's dangerous when the gardener is allied with one group over another. I painted her red. That's why she prefers red over pink. And it's dangerous when she's not concerned with equity, when she can look at her garden and think it's beautiful because she's not even really counting the pink flowers as part of her garden. And so our challenge is what to do about the gardener. Do we try to make her polka dotted or striped or fuchsia? Do the pink flowers have to grow or recruit their own gardener? Lots of questions that can come out of this story, and I hope that we'll have time to engage some of those questions. I just have to share one of my favorite questions that's come out of this, and that shows the power of the story, too, of allegory. Because the question was, why should the red flowers share their soil? Right, if we were talking about racism between you and me, we would never even get that question, but you know. But this is an important question, and my answer to that question is that soil does not belong to the red flowers, it belongs to the garden. So, amen. So now I'm going to just spritz through a few other things so that we can get responses from our respondents. I've just said that institutionalized racism is the most important thing. There are two elements to measuring institutionalized racism. The first is asking the question, could racism be operating here? Where we look not only at outcomes by race, different outcomes by race. To me, those are the disparities, counting the different numbers of different colored bodies at the bottom of the cliff, but also looking at differential opportunities by race. That's when you're actually making the boxes transparent, when you're trying to say, let's talk about the differences in the quality of the soil. But even if we said, yes, racism could be operating here, and we could just look at the way education is distributed or income or housing right now, today, yes, racism could be operating here. That doesn't give us a way to get some traction on it. We need to also identify the mechanisms of this system in our structures, policies, practices, norms, and values, where to me the structures are the who, what, when, and where of decision making. So who's at the table and who's not? You know, what's on the agenda and what's not? And actually, I encourage people, whenever you find yourself at a decision-making table, to look around and say, who is not here who has an interest in this proceeding? And then when you figure that out, it's not your job just to represent them, but to try to find a way for them to get to that table. When you are in parts of your collectives, because some of this is not just going to be about your individual ability to tackle racism, we have to develop a sense of collective efficacy. We're parts of lots of collectives. We're parts of neighborhood organizations. We're parts of faculties and student groups and parent associations and all. We need to put important things on the agendas of all of our collectives, right? So structures are the who, what, when, and where of decision-making. Policies are the written how. Practices and norms are the unwritten how, which sometimes are harder to get a handle on. And values are the why. And we need to pay attention to all of these things. We need to take the question, how is racism operating here with us, to all of our venues, to this faculty? How is racism operating here in Baltimore? How is it operating in my child's school? Everywhere. So I have defined racism as a system of structuring opportunity and assigning value. I just want to just hit, boom, 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 some of the challenges and strategies around the two aspects about changing opportunity structures and about valuing everyone equally. In this nation, we are an ahistorical people, and we need to understand the importance of history if we're going to, and we have to raise the importance of history. And actually, in achieving health equity, I think we need to value all individuals and populations equally, recognize and rectify historical injustices, and provide resources according to need. This is inherent in achieving health equity. But understanding the importance of history means that if I've been bicycling up a hill, and you've been coasting down a hill, and now we're going to have a race here, we have to understand we are not in the same position, right? And we have to acknowledge that. We need to challenge the narrow focus on the individual that is inherent in our culture so that we can understand that we are all of us, and we have to develop an interest in our own common humanity. We need to view systems and structures as modifiable. Just because you were born into something that was this way doesn't mean it has always been this way or always needs to be this way. And we need to develop a sense of efficacy to actually change systems and structures. We need to transform from being a nation of consumers to being a nation of citizens. We are educated to be consumers. We're not educated to be citizens, to be widely read, to speak more than one language, to travel and on. We are educated to buy things, and we need to challenge that. And I further encourage us in our work. You know, so many of us are trying to do good work, and we're working on anti-racism stuff or health disparities or equity and all of this stuff. We need to, even when we go home, continue our lives as citizens and engage in the same work in our private lives as well as in our professional lives. We need to expose the myth of meritocracy. What do I mean by that? Meritocracy, what that means is that if you work hard, you will make it, right? Well, most people who have made it have worked hard. Not all, but most people who have made it have worked hard. But there are many other people who are working just as hard or harder who will never make it because we are dealing with an uneven playing field. And we have to expose that myth, because if we deny racism, if we deny that uneven playing field, then we are saying those people who haven't made it must be stupid or lazy or something like that. When in fact, that is not the case. We have to address the inequity. We have to address racism and dismantle it. We need to do two things. We need to break down barriers to opportunity and also build bridges to opportunity. And actually, the Johns Hopkins institutions have an opportunity to build those bridges so that you don't have to have known that you wanted to be a doctor since you were in junior high school in order to be a doctor. Maybe you're a med tech and you had to go and take some time off from school and all like that, but maybe we can build a bridge so you can come back in and be a doctor. In terms of challenges and strategies around valuing everyone equally, first of all, we need to find ways to break out of our bubbles to experience our common humanity, and institutions need to structure ways for employees and students to break out of their bubbles. Many of us travel in little bubbles where we come to school or work, and then we go maybe to our church or our kids' school or whatever, and we just like boom, 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 and we have no idea how people across town are living. But if we were to break through our bubbles, then we would find that there are people across town who are just as funny, just as generous, just as smart, just as hardworking as we are, but have very different life situations. We need to experience that to understand our common humanity and then be motivated to do something because of our common humanity. We need to embrace all children as our children. Don't be thinking about my children and your children. These are all children, all our children, and these are all our future. We need to not ask, what are you? But who are you? And be interested in each other's stories and not just make snap judgments on surface appearances. We need to insist on parity, inclusion, and representation in decision making. That's how you really show that you value somebody, right? You want their input. And we need to confront the reality that our economic system profits from unequal valuation. And so that might make things just a little bit harder. So I'm going to leave you with a few more things. Who has ever heard of this? the International Convention on the Elimination of All Forms of Racial Discrimination. A few people, I see about 5 hands, okay? This is an anti-racism treaty that was voted into existence by the United Nations General Assembly in 1965. Did you know that there was an international anti-racism treaty? So, do you think the U.S. has signed this treaty? No. Right. Yeah. We signed it in 1966. But of course, just signing a treaty doesn't mean anything because, when you sign a treaty, then the Senate has to ratify it too. So, okay, bets on, has our Senate ratified this treaty? Yes. 28 years later, but in 1994 we ratified the treaty. What does that mean? It means that we have international treaty obligations to do right by this anti-racism treaty. You can find the treaty, by the way, at www.un.org or just Google ICERD, this thing. So what are our obligations? Our obligations are to do right and also to submit periodic reports. So we're asked to submit reports every 6 years. So we submitted our second report to a UN committee in 2007. You can find the report there. You can find it if you go to the State Department. The State Department is the one that writes our reports. And of course, lots of non-governmental organizations also submitted so-called shadow reports to this committee. So the committee gets the reports, and what do? They don't just read them. They send us something back that they call their concluding observations. So we got our concluding observations back in 2008. It's only 14 pages long. It is not a telephone book. We should all read this tonight, okay? And it starts out by saying, thank you, United States, for your report. We remain concerned about racial profiling, residential segregation, disproportionate incarceration, differential access to health care, the achievement gap in education, and on and on and on. 43 paragraphs, I believe it is, of concerns and recommendations. It also says, dear United States, you need to establish a mechanism for ensuring compliance with this treaty at the federal, state, and local levels. And it further says, dear United States, you need to let your people know about this treaty, right? So I'm doing my part. Now, every talk I do, I let people know about the treaty. So this is actionable. This is actionable. So I am going to close now by saying that our goal in all of this has been to expand our conversation beyond the single dimension of health services to talk about addressing the social determinants of health, including poverty, and addressing the social determinants of equity, including racism. And I have 3 tasks to leave you with. The first is to put racism on the agenda. Don't stop at race. Go all the way. Racism, which is the system that makes race pertinent in the first place. And we need to name it as a force that determines the distribution of other social determinants of health. And we need to routinely monitor not just health disparities, the outcomes, but also differential opportunities and exposures by race. We need to put racism on the agenda even after the election of President Barack Obama as our president, because his election did not signal the dismantling of racism. It signaled a change in race relations for enough people to get him elected. The second thing is we need to ask the question, how is racism operating here? And take this question with us everywhere, looking at the mechanisms in our structures, policies, practices, norms, and values, where the structures are the who, what, when, and where of decision-making, policies are the written how of decision-making, practices and norms are the unwritten how of decision-making, and values are the why, looking both at what exists and what's lacking. And finally, we need to organize and strategize to act. And when we do that, we need to link with similar efforts across the country and around the world. And I encourage all of us to become actively anti-racist. You can't be a standbyer on this one, right? You have to become actively anti-racist so that we can dismantle the system and put in its place a system in which all people can know their full potential and have the opportunity to develop to their full potential. So thank you very much.
Camara, thank you. I'd like to invite up the 3 reactors to start the conversation. And as they come up, I will introduce them. Reverend Francis Tony Draper is well known to a number of people, clearly, and is the founding pastor of the Freedom Temple African Methodist Episcopal Zion Church in Brooklyn. The church originated here, just a couple of blocks north, and moved, 2 years ago or so, Tony. Dr. Draper has just a stunning CV. Just to touch on a few things, I won't read all of her master's degrees because she has 3. She received her doctorate of her ministerial doctoral degree from United Theological Seminary in Dayton, Ohio. She has had a career in business and journalism and in theology. To her left is Dr. Maria Trent. Dr. Trent is an associate professor here in the School of Medicine at Johns Hopkins and has a joint appointment at the Bloomberg School of Public Health. And to her left is Dr. Chris Gibbons, who is an assistant professor here in the School of Public Health and is an associate director of the Urban Health Institute. Together, these individuals bring perspectives from theology, from medicine, from public health, and all from Baltimore, with a deep understanding of some of the rocky soil in which we do our work and live. I'd like to perhaps turn it to Pastor Draper to make some observations or comments.
Thank you, Bob. And let me say to Dr. Jones, thank you so much for such an insightful and thorough presentation. We appreciate you. I could not help but notice in your allegory the similarity to the parable of the sower. But I'm not going to preach this afternoon, but that is certainly a reaction. There are so many reactions, so many things were going through my mind as you spoke. But if we take the last thing first, where you listed some action steps, the first thing that hit me was that we have to acknowledge that racism exists.
That's right.
Before we can even start to work on anything, and so many people don't believe that it does. And so while I appreciate this opportunity to be on this panel of distinguished medical professionals and in this wonderful place with all of you here, I couldn't help but notice sitting there that all of us who were going to sit here on this panel were of African descent. And so having said that, that's fine. But I want to also say that there are times that when we have these discussions, we'll find the panel is all African American. And that may suggest, not necessarily, that there are some, that we're the only ones that can talk about this issue, and that's not so. And so the ownership of this issue is not a one race, and not that anyone suggested that, that's just a visual. But it's something that we all must own. If we don't acknowledge that it exists, we will never work cooperatively to see how to best address. The other reaction I had so many reactions, was that there's racism within race.
That's right.
We tend to categorize racism as one race versus another race, but there is clearly racism within race. And my third observation, these are just observations and reactions, is that when research is done and data is gathered relative to race, we don't list race alphabetically. We tend to list it by what we consider to be the majority. So even how we structure research or research questions should be looked at. If we're going to do anything and try to level the playing field, we may as well just do it alphabetically instead of putting white first as our choice. Because the messages that we send through media and in writing have a subtle way of suggesting how we prioritize things and what we think is better than something else. I'll stop at those three.
So I have a disclaimer. I was in Dr. Joe's last race and racism class at the Harvard School of Public Health in 2000. And so for people who know me, I'm a little bit, and so, but I think her class was really instrumental for me, I think, as a budding health professional, both medical and public health professional. And I think has shaped my experience in the kinds of work that I do, I like to say on the side here at Hopkins, in terms of my idealism and believing that everybody can get off the conveyor belt to make a difference in terms of health disparities and in terms of understanding racism and difference, not just even racism, other kinds of isms that can impact us all. I think I'm sitting here worried because I believe, though, that like individual behaviors which we believe are, or which we know from public health research are so hard to change, so hard to get people not to get STDs again, so hard to get people to do lifestyle changes to prevent obesity and to deal with hypertension. And I think the same is true to some degree when it comes to racism and how we behave about it. I think it requires us to be conscious in order to step off, and the conveyor belt thing is Beverly Tatum's, it's completely not mine, but it requires us to really take some active strategies to do that. I have seen people in some of the seminars that I think that I've taught with some of my colleagues who are here, I've seen people change. But it's not the public health model. They change in groups of 15 at a time, which is, I think, what she was alluding to in terms of these small groups or seminars. And it really does take a shift in from an environmental perspective to, I think, make a difference. I think my worry is I think we still have to do that because I think in places like Hopkins trains leaders. And I think that leaders, in order for them to sit at the table and say that I'm going to now divide the soil up differently, they have to have gotten off the conveyor belt in order to do that. And I think that we just still have a lot of work in that area so that conversations like this and the smaller ones we have over in the Department of Pediatrics with our group can happen so that leaders can begin to think it through, so when they put their public health hat on or their medical hat on or their research hat on, they've got that inside somewhere and it guides their work. And so I think that that's still a place that we're trying to grow and change in terms of addressing racism in big institutions like this one.
Well, I'm struggling. And I tell you why I'm struggling, because as Pastor Draper said, there's so many reactions to this. I guess I should have a little disclaimer also. I'll let you in on a little bit of information that not many here know. I think I have a perspective on this that is unique. I was actually born in Jamaica. My parents were immigrants. My mother from Jamaica, my father from Guyana, South America. And they were the first in their families to come over here, and my father became the first PhD trained person, and through him everybody else came. And the same thing on my mother's side. We lived the first part of our lives in Boston, Massachusetts. I went to white schools. And then when I was in going into high school, we had a bit of culture shock. My folks moved to Alabama. Things were very different. So I lived in Massachusetts. I lived in Jamaica, lived in Massachusetts, in white society, but in a West Indian Caribbean home. Some of you don't appreciate what I'm saying, but that means something. And then moved to Black America and went to high school and college, and then went to the University of Alabama Medical School, where they didn't accept the first black until 1964, the year I was born. and then I came here. So there are many perspectives, and to me, and let me just say, I agree with everything, but I don't see it as quite so simplistic, and it's not simplistic, but there's so many facets to this that often don't get talked about. And one is, with all respect, I think there is a side of this in this country that the black man experiences that the black female does not and cannot fully understand. And that's not to take anything away from Dr. Jones. I'd be interested in hearing what she thinks about that. But it only shows, and my orientation to life, to problems, to everything is fundamentally not one of epidemiology, but one of solutions, pragmatism, and how do we get from here to there. I admit, I agree, it's here, it's a problem. But my question, my focus is, how do we fix it? And so I think in terms of what are the challenges to doing what she's talking about, and how do we get there? And I think just to talk about one or two, just because there could be several. I think Dr. Draper illuminated one. If we are not willing to recognize that this concept of racism can happen within our community, then it makes it very difficult from those outside to say, you know, you're not serious about this. This is just you trying to get back, or, and not that we don't have a reason to want to get back or whatever, but these are some challenges that I think are there. I mean, is it fundamentally at our core, when we try to associate with people like us, when we put it in that way, nobody sees a problem with that. How many blacks go to a black church? Is that wrong? In that black church, I've attended black churches where if a white preacher comes to speak, half the congregation leaves. Is that racism? Is that wrong? How does that fit in with this? And how do we get from here to where we need to be? I could talk about others, but I'm sure you guys have a lot of questions too. And so I'll stop there, but I'm sure they'll all come up.
Why don't Dr. Jones give you a chance to reflect on what you've been hearing, and then let's open it up for questions and comments.
Actually, respectfully, I'd like to get more questions on it, and then I think all of us could make responses. Like, if we could get 5 questions at a time, and then we can all respond, and then 5 more questions, because I really am interested in what you all are thinking as well.
Great. So, what I would just ask is 2 things. Introduce yourself, because the betting odds are not everyone knows everyone in the room. And 2, please be brief with your comment or question, because there are numerous hands. You're up.
Thank you.
Oh, they're mic. They're taping it. You need a mic here.
I want to thank you so much for having this forum, and thank you for having the panel. And I'm Reverend Daki Napata, just Brother Daki. The restriction on the comment and the question is an act of racism. Let me say it again. The restriction on the comment is an act of racism, whether it's conscious or unconscious. I'm not saying man is racist. I'm saying the structure to have a forum where you have this much information given, and then by the time you get to the people and their input, it gets minimized. That's an act of paternalism, racism, rationalism, empiricism, and limited time. Now, having said that, and I thank you for trying to coordinate this. It's not personal to you. One thing I would like to say is that, one is I taught race relations in the Department of Defense. I taught it in Vietnam, right? I was highly decorated for doing so, and found it a very difficult thing to have mandated by the military, because we had racism. We had a war going on within a war. We had black soldiers waging war with white soldiers in Vietnam and other places, you know, following what had happened in Tuskegee and the like, you know, Tuskegee and the Red Wingers and the like. And my general was Chappie James, a 4-star general, who gave us resources so that black soldiers could fight against the racism we had confronted in a war zone, let alone around the country. So I just want to put that out there. There was a brother, and I'll be brief. There was a brother named Dr. Harry Catano out of UCLA. He was a child who was born in internment camps in World War II, Japanese American, who taught sociology at UCLA. He wrote a very small book called American Racism, the two-category system of racism. And basically what he said was, in brief, there are two categories. That all whites are believed to be superior to all non-whites, period. That all whites are believed to be superior to all non-whites. And then all kinds of systems support that premise, that foundation. That all whites are believed to be superior to all non-whites. And the stereotypes supported, the ethnic jokes supported, the structural racism supported, the genocide of Hitler supports it, the extermination of the Indians supported, on and on and on. The enslavement of Africans supported. I say that to say what? That that's a resource that we might want to look at. The last thing is this. I believe that when we, and my brother mentioned it, that when we approach the notion of racism, it minimizes the impact of the violence of white world supremacy. Let me say it again. I think when we use the term racism, personal and institutional, it minimizes the impact of white world supremacy. And by that I mean a handful of people who decided based upon their belief system that they had the right to conquer everything place they went. They came as guests and they conquered every place. They had manifest destiny. They came in, Native Americans were here with their lifestyles, and they had the right by their God and their interpretation to dominate the people, the land, and cause extermination and genocide. They said did the same thing with Africans in the Middle Passage and the like. And I say that when we heighten this notion of institutional and personal racism to that category, then it's better then we're better able, I believe, to understand the clash of civilizations that happened. African societies and the people of the earth were matriarchal systems. The societies they confronted were patriarchal, and they were dominated. They were dominant, you know, whether it was Greek or Rome, you know, or other folks, the Arab countries that invaded Africa and Native Americans alike. And when we see the clash of civilization, then we as healers, my final point, we as healers looking at that, do not look at a rational and empirical approach to understanding it. It's not rational, you know, it's rational versus spiritual. Africans were about being in relationship with themselves and everything in the cosmos. That's why they could heal the way they did. I'm almost through, sir. Greeks were about things, owning things. Romans were about things and military might. And when you have the confrontation of those two different cultures, then you have a clash of civilizations, whether it's Europeans going into South America, the Mayas, the Aztecs, and Incas in search of things, gold, right, or going into diamonds. And so what I'm saying is I would challenge us that if we're serious about a healing model, that yes, you've done some magnificent work, then let us confront the holistic dynamic of how people feel about this white world supremacy, how people feel about the fact that Johns Hopkins is a mega industry in this town that gobbles up communities, that there were black and poor communities in this neighborhood that they continue to gobble up by eminent domain and have very little sensitivity to it, contrary to some of the good work that may be going on. And when people see Johns Hopkins or the University of Maryland, they see that type of imposition of a very rational, dominant, military-industrial complex that occupies their territory. And so if we're to confront what goes on inside of Hopkins so that students can get a different sensitivity, then we have to confront the reality that Johns Hopkins is an imposition and not a friend. Thank you.
Dr. Cooper.
Hi, I'm Dr. Cooper from the School of Medicine.
We can't hear you.
It is on. Hello? Okay. I'm a professor in the School of Medicine. Thank you very much for this very stimulating conversation and for all of the stories that you shared. You talked about the fact that racism saps the energy and the resources of the entire society. And so I was just wondering if you and also other members of the panel would care to comment on how it is that racism not only impacts in a negative way on the disadvantaged populations that are affected, but also by the individuals who are privileged within the society who might also be harmed by the effects of racism. So how do we all end up losing in this overall problem, and what do we all stand to gain by overcoming it?
There was early on a comment or a question somewhere in that area. Is there still? No.
This one right here. So,
Please introduce
yeah,
yourself.
Michael Scott, Equity Matters. Please add our like on your Facebook, Place Matters Equity Matters.
Use the mic because you're
Chief, what?
taping it. They're taping it.
Oh, okay.
Maybe actually one person can stand with the mic and people who want to talk can make their way to the
Hello?
one person, or the two people with the mic.
So, Michael Scott, Place Matters, Equity Matters, and I gave a cheap plug. Please join our like page on Facebook, Place Matters, Equity Matters. My question is, I'd like to challenge you, Dr. Gibbons, and through you, Dr. Jones, because I heard something that I often hear, and I took issue with it recently on the radio, but you described black folks walking out when a pastor, white pastor, come, and my understanding of racism versus prejudice, bias, ignorance, and bad behavior is the system of power. So my understanding is that therefore people, at least in this country, of color cannot be racist because they don't have the system of power. So can you comment and tease that idea out of them? Because I think in an effort to be generous and balanced, we often perpetuate the misunderstanding between personally mediated bad behavior and the ism of race, and I think that needs to be addressed clearly.
Let's take a couple more and then open it up. And if you have a question or comment, raise your hand so we'll give you a mic.
Actually, if you could just stand behind Ariel or stand over here, that would make it a lot easier.
Hi, my name is Mindy Flamholtz. I'm an independent education advocate, and I've done some work in Baltimore City schools. And if we can go back to that image of the garden for a minute, and think about the rocky soil. Our kids don't go outside to play. There are no fields. The soil's rocky. The playgrounds are rocky. Our kids don't get the sunshine that they need and the plants need because they don't go out to play. I don't know much about the plants needing vitamin D, but our kids need vitamin D. And as we all know, there's so much pressure now because of No Child Left Behind that the kids have to stay inside longer. I just actually worked at a school on the east side of the city today. These were kindergarten kids. 90% of the time they were reading, maybe 10%, no, a little bit less than 10% of the time. My numbers are going to be off here. The point is, a lot of reading, a lot of math, almost no socialization. I had the choice of whether I wanted to take them outside for recess or not. Our kids are not going outside, they're not running, they're not playing. The obesity piece kicks in. They're not learning how to socialize. We bring in anti-bullying programs, but we don't give them time to learn in very natural ways, conflict resolution, and to make friends. Their neighborhoods aren't safe, so when they get home from school, they're not going outside and playing. And our policies are not getting our kids physical education, physical activity, and outdoor recess. And when you were talking about solutions, there are policies in place that aren't being monitored and implemented, monitored, and evaluated. There's a wellness policy that's in Baltimore City schools that really nobody pays much attention to. There's a resolution in Baltimore City Council to increase the physical education requirement. If you ask them where it is right now, you can call the City Council, they really don't know where it is. There's a bill before the General Assembly to increase physical education time for exact minutes of physical activity and physical education. My bottom line is that these disparities start not just when our kids are born, as we all know, but in school. And if our kids can't de-stress, get fresh air, run around, learn through the discovery of being outside, being creative, most people here, their fondest memories of elementary school are often being outside at recess. That's when you made friends. That's when you discovered things. That's when you could be creative. That's when you could imagine that the playground was a spaceship. Kids in schools can't do that.
Thank you. Let me just point out the obvious. There are 6 people standing to make comments or questions, and it is 5 o'clock. Please be brief. And we'll cut it with the people who are standing.
Thank you. My name is Lynn Bowens, Maryland Department of Human Resources, and I had a question for you. I'm rereading Chancellor Williams. Somebody said it. Somebody said it, yeah. Destruction of the black civilization. Chancellor Williams. And in it, he said at a very young age, at 10, he started to see the disparity, even at 10 in the 5th grade. Why were the white schools better than at that time, colored schools? And it started him on a journey of seeking. But one of the points that he makes is one that I see daily as an African American in this country, as well as living in Baltimore City, the hate on hate. He said at a very young age he wanted to figure out why blacks hated blacks as much as they do. In all of your studies, have you started to figure that out? The only thing that I keep going back to is that the slavery and that whole era, it never gets out of you. And I'm thinking it's in your DNA. It must be passed down somewhere through the genes. I know about Willie Lynch, and I tell people all the time I do believe in that letter, that whole system of just splitting the races, the men not living with in the home with the children. Now we see black men having children, leaving the homes. It's like a reproduction of slavery, but this time it's supposed to be in a civilized society. But I see that whole era of Willie Lynch reproduced every day in 2011. So my question, have you in your studies, please, figured out, help me please, why black on black hate is at its highest in 2011?
Please
Hi.
introduce yourself.
Hi, my name is Demia Whitaker. I'm a postdoc here at Hopkins and at the National Institute on Drug Abuse. And I grew up in an urban city, and actually in Washington, D.C. And through my experience with my education and growing up in D.C., I found that quantification and empirical evidence seems to be needed before change is made. So here at Hopkins and here in Baltimore, whatever, I've had the pleasure of working with Dr. Deborah Verholden, who developed a tool for quantifying neighborhood physical and social disorder in urban disadvantaged communities. So in the context of differential access, I wanted to know how do you envision tools like that on a national platform being used to address social determinants of health, since quantification is so important?
Thank you.
My name is Kyle Dawson. I'm an educator in Baltimore City. I was curious about that metaphor of the gardener. Two things. First part, were you presuming that all red gardeners would prefer red flowers, or was that just a general example in that? I can speak from my own personal experience. I have no white students, and I was curious if you believed I had intrinsic prejudices that I wasn't even aware of. And the second part was your soil analogy. You defined what the gardener was in your question, but I don't think you defined really what the soil was for me. I know that some more complicated plants you have to go from pot to pot to pot. Now, are you demonstrating that if they get deficient soil early on, it cannot be made up later on? Thank you.
I'm Victor Urrutia. I'm a faculty in the Department of Neurology here at Hopkins. I love your talk, and I think that your idea is very compelling, very interesting. I think that when we're looking at investigating the causes for disparities in health, it would serve us all well to think about what you're stating and look at racism as opposed to trying to find biological differences. And a lot of the research that is done, unfortunately, focuses on that. You know, do African Americans or Hispanics or Chinese have this gene that makes them puts them at risk of a different diseases? One of the ways of to help dismantling the institutionalized racism may be to finally come to accept that race is a social construct. It's not a biological entity, and that with also accepting that the system of racism has to change would be a good way to approach it.
Hi, my name is Sarah Peitzmeyer. I'm a student here, and thank you all for coming here today. I was wondering if you could talk a little bit about other systems of privilege and whether you conceptualize them as some larger set of systems and how that fits into your allegory. How does it affect people's experience and their health to be in multiple levels of flower boxes, and how that works into your story? Thanks.
My name is Floyd Gotzi. I'm currently the president of BSU at Essex Community College, and I have a question. There's an obvious gap between the elder generations and the younger generations coming up, and what can we do to bridge the gap and really, get your message across and get their attention? Thank you.
Well, certainly some questions for thought and reflection, and it is open to any and everyone to respond.
I'd like to start and just, I think I have 4 things. I can't, but some of the questions we'll have to just do it afterward, because I want to give everybody else a chance. But I wanted to start with, I don't even know which, this is the answer, I don't know what the question was. But there has been such a profound devaluation of African American life, American Indian life, Latino life. There's been such a profound dehumanization of us that I wish I remember what the question was, but it's important to know that so when we hate each other, I think it was about why we hate each other in black. It's because the whole society is communicating that we have no value. And so we need to combat that message. We need to, and it's not just a psychological thing of combating that message, it's like really investing in us, really wanting our input, really cherishing our children. I mean, once we're really valued, then we won't feel devalued. In terms of other systems of privilege, that definition of racism that I gave as a system of structure and opportunity and assigning value based on race can be generalized to a generalized definition of structured inequity. So we could say, what is sexism? It's a system of structure and opportunity and assigning value based on gender, which unfairly disadvantages some, unfairly advantages others, and saps the strength of the whole society. And there are many, many axes of inequity going on in this country: race, gender, geography, nationality, disability status, sexual orientation, lots of them. And none of these, in and of themselves, confer risk for health or anything else, but they are markers for how opportunity is structured and value is assigned. I acknowledge that all of these things are going on at the same time. I spend my research and thinking focused on race as the axis of inequity and racism as the system, because racism is foundational in this nation's history. And yet, many of us are walking around as if racism no longer exists. Racism is alive and well and having very bad impacts on the whole society, and so that's why I do that. But I acknowledge all these other systems of privilege and systems of inequity. In terms of the gap between generations, I see that too. And part of it is that those of us who grew up, especially people of color who grew up during some of the struggles of the civil rights era, think that our children should just know these things, but we're not actively teaching them our history. So there are many children now, many young people of color who feel like they got where they got, if they've gotten someplace, because they're smart. And surely they are very smart. But there have been smart people of color in this country for centuries who could not get where they were until opportunities were made available. And we're all standing on the shoulders of others. And it's important, the sense of history is important not only to understand where you came from, but to understand why you must stand tall so other people can stand on your shoulders. And there were many other things, but I'm going to pass this on so other people can make comments.
I would just tell one story that Congressman Elijah Cummings tells that highlights the point that you just made. He said when he was sworn in as a congressman, his father was present. And he said afterwards there was a reception, and he expected his father to be giddy with joy. And he said his father came up to him with tears running down his face. And he said, "I am so proud of you, but I could never have been where you are today." He said, "My tears are for the generations that could not stand in this hall." And I think it is very telling of what you said. Pastor Draper?
Well, a couple of things. Lynn, I think that for the black on black hate, as you called it, I think a lot of times the oppressed become the oppressor. Wow. So I'm not going to say a lot more about that. I do think that history is so important. And what I find when I talk to people of different generations, especially amongst those who did not grow up in the civil rights era, many want to move, in their minds it's not their problem. They want to move beyond that because they came up in a different time, in a different place, in a different educational system. And sometimes we don't even recognize when it's institutional racism or whether it's our person. We just don't. Many people do not wake up thinking about race. and racism. And sometimes we segregate ourselves based on other things and not just race, our comfortability. So I must speak to the gentleman who talked about church. The 11 o'clock hour, for those of you who celebrate church on a Sunday, for example, is the most segregated hour in America. If you look at the history of the African American church, for example, it'll give you a different perspective as to how the black church came into being. I don't want to spend a lot of time on this, but in our tradition, we were part of the Methodist Episcopal Church, where blacks had to sit in the balcony, baptize their children last, and have communion last. And the only time a black minister could preach in that church, even though it was integrated of sorts, would be after everything else was over. And so people formed separate denominations, which I just call mini-nations, to have a comfort level in worship. And so it perpetuates. I don't believe that there ought to be a black church and a white church, but people tend to congregate where they are comfortable. And I do think if someone walked out on a preacher, it was bad behavior, not necessarily racism. My experience has been that the white preacher does better in the black congregation than the black preacher does in the white congregation, and don't let it be the black female preacher in the white congregation. That's just a personal. And and the last thing, someone was talking about the your allegory of the garden. Wouldn't it be wonderful if some of those seeds just blew from one pot to the other and they would cross-pollinate?
Dr. Trent, any final comments upstairs?
Well, I always have comments, but there were a lot of things that people brought up. I think the drain on our society is significant to everyone. I think that America has gotten a report back that we're not able to compete in the world as well as we could be, and the impact is likely from the fact that we haven't invested in everyone the way that we should have. Someone talked about how we haven't invested the rocky soul and how we haven't invested in our children, but I think we're at a unique time period in our country. From a political perspective, there have been major cuts to the Maternal Child Health Bureau that are going to affect programs like WIC and some of the programs probably that affect my population, potentially in adolescent health. The maternal child government is taking sort of a life course approach to child health in the United States, but somehow it ends at age 5, and we're not helping young people make it successfully to adulthood. I work as a consultant for the Baltimore City Health Department. I've been in 8 of the, I've worked in 4 of the largest high schools in Baltimore, and I think it's been a struggle. I have a young child who's in public school in Howard County, and I went to do a presentation with her. I've told her before, and I took all this stuff because I thought I was going to have to set up this PowerPoint to help her do this presentation. Okay, I'm a little top parent, but the teacher in the kindergarten class had PowerPoint set up, and they use it on a daily basis in these classrooms. And so for me to visit Baltimore City schools, where we have one of the most innovative school-based health programs for high schoolers in the nation here. It's not pretty, but it's innovative and it's comprehensive. But I think those things are at risk, and so even the CDC may be cutting the DASH budget, which is providing school health programs to young people. So I think it's a time for us to think carefully about how elimination of those programs may further disadvantage young people, particularly those of color or those who are poor even, across the board. And so I think it's time for us to do something about those things as well, because I think in the end, the racism could feed into how they play out because of the safety net it provides. I think tools to examine these things are important, but I think they also have to have opportunities to be funded, and someone has to pay to do the research. I think my research here on health disparities, mostly around reproductive health, data speaks, training people to do the research, to show you the numbers. What was powerful here was the gardener's tale. It was powerful for me 10 years ago, 11 years ago. It's powerful for me now. But what was even more powerful was that she showed you her epidemiological skills, and she showed you how those numbers came together, and we need people to be able to break down the data like that for us. I think the final thing is that she mentioned that this whole notion of slavery and its impact on American way of life and how we think about things is important. But even with the end of slavery, discrimination continued in the United States for many, many years. Hospitals weren't segregated in many places. I grew up in the rural South. In 1970. I don't want to tell my age, but this is around. In my lifetime, things have not been equal. And I think that now there are new people who are rethinking how we're living now, and some people think that he talks about the prison industrial complex, but the reality is that incarceration represents the new Jim Crow in America. There's some really wonderful scholarship that one could read to really look at these issues. So I think the issues are so great and so abounding. I think he's right, this gentleman, that we could stay here. We could probably have like 3 days, and we could all sit here together and try to solve some of these issues. But I think there are a lot of issues still out there, and I think that this type of activated audience is important. The final thing, I can't remember your name, to the man in the blue right here, and you said you have a class of all black children, and you wanted to, all your classes, and you wanted to know whether or not you held all these intrinsic values. And I think the thing I have to say is, it's important that you're here. You are already stepping off the conveyor belt in ways that many other people are not. The fact that you've been questioning it is important, because that means you go back with your groups and you're activated, and your presence here is important. It sort of goes to the first comment that Reverend Draper made. And I think that it's so critical that you're here. I think it's empowering for the rest of us to see you here, and I think you're gonna be able to help your students better because you're so activated on these issues. You're conscious, man, and I think that's important. Not to single you out.
So there are a lot of things, and we don't have time. Time is gone. So let me leave you with maybe 2 thoughts, just 2 thoughts. One is that the young lady talked about quantifiable methods, and we talked about the epidemic and research questions. But for me, I think fundamentally this topic, if this is just a research question, we would have lost the opportunity that may potentially be before us. It has to be something more. Research is direly important and we need it. But if it's just a research question, if it's just about genes and chromosomes and poverty and society, I think we will have lost the opportunity. And as a part of that, if there is a research question, perhaps one of them is racism the problem, or is racism an example of a much bigger problem? And the answer to that question will lie in where you start and where I start and where I come from. It is an example of a much bigger problem. So I encourage you to get involved where you are, do what you can, but never let it be just a research question.
Well, thank you. Thank you all. This has been an extraordinary afternoon. I think that it will be more extraordinary if in a week, in 2 weeks, in a month from now, I hear in the hallways of Hopkins people talking about and thinking about some of these issues, and in the classroom, some of these issues being discussed, and in the Northeast Market, that people are talking about some of what they heard, and think about how to make those bridges, and on Eager Street and around this community. You've given us a tremendous amount to think about, and you have given us a way to think about it and a way to talk about it. So thank you, Dr. Jones. Thank you. Thank you, Pastor Draper, Dr. Trent, Dr. Gibbons.